CLS is one of those very interesting things that I think is foundational for our practice and really offers patients a very unique opportunity to have their most physiologic state restored for them. So this is about the rate adaptative pacing algorithm with CLS, focusing mostly on experiences that we've had in clinical practice. So just a couple of disclosures. And disclaimer, this is broad informational topic. It's not for specific individuals. So we can first ask the question, what is CLS? So we think that this is a rate adaptive pacing algorithm using a contractility-based pacing sensor. And what are the goals of CLS? It's to reproduce the most physiologic heart rates possible in our patients. So which biotronic devices have CLS? CLS is only in the biotronic devices. Which ones can do it? There's the dual-chamber MRI-compatible pacemaker. This is the Entovis DR model. We'll have it. There's the single-chamber MRI-compatible pacemaker, which is the Entovis SR model. Their CRT-P platform has it. That's the EVIA HFT. The CLS is only possible if you program an LV offset of 0. So the minute you add LV offset, CLS at the present time becomes disabled. So you can have it for CRT-P, but just remember that caveat. Right now it's only with an LV offset of 0. And now very recently approved, the dual-chamber MRI ICD, the Atrial, has CLS. So if your patient is chronotropically incompetent, has a dual-chamber MRI, you can provide CLS-based pacing in an MRI ICD platform. And that's brand new in the last just couple of months.
MRI is still not approved in the US for ICDs, though.
Okay, MRI's out, but the CLS platform's available. That's coming, though, right?
Yeah, it is, yes.
Okay. Soon to be approved. So we're anticipating approval. So advantages of CLS, and this is the literature advantages that have been demonstrated. One, chronotropic incompetence, I think the most practical use, providing a physiologic heart rate variability for our patients. Also a very special role in neurocardiogenic syncope. So it's upstream anticipation of the reflex bradycardia, which results in faints in this context, and we'll talk about that a little bit more. Providing physiologic pacing rates in the atria has been shown to reduce atrial fibrillation, so that's nice. And there is, at least at the abstract level, evidence for improvement in LV ejection fraction if you provide a physiologic heart rate using CLS. So sensors for rate adaptative pacing. We're always trying to adjust pacemaker sensors to give our patients sort of the heart rate variability that they deserve, they want, allowing them to exercise and perform in life. We have accelerometers. The first sensor. Pros to this is the fast reaction to exercise, that the sensor is proportional to the workload that the patient is trying to attain. Cons are that it can be fooled by certain motions, and these were the days when people would drive on bumpy roads and the pacemaker would be speeding them up because it thought they were exercising. And then there is no non-exercise sensitivity. So in fact, our heart rates like to fluctuate a lot when we're not doing anything, and the accelerometer cannot reproduce that. This was improved upon to some extent with minute ventilation sensors. This is nice because it's physiologic, but in point of fact, it requires hard breathing to activate that sensor. And we don't start to breathe faster until we've been exercising a while, so it takes a while for that sensor to pick up on the fact that we're moving and adjust our heart rates. And also, like I said, so a delay from the exertion onset until you actually start breathing faster, and that sensor can compensate for you. So then the idea of a blended sensor combining the accelerometer and the minute ventilation came along, and those were some improvements, but still not without some limitation. So the closed loop stimulation is a third sensing option, and what are the possible advantages to that? It's based on the contractility of the myocardium, which can make it sensitive to subtle physiologic changes, which patients appreciate. So motion and breathing are not required. So looking at sensors again, the accelerometer having its largest influence at rest, which is an advantage. With little bits of, with small motions, the accelerometer could pick up on this. With heavy exercise, the minute ventilation centers tend to perform better. So they have their largest influence as the workload really increases. Where these sensors both don't perform well is in that activities of daily life range of motion, where the patient isn't moving a lot, they're not breathing hard, but they're still busy, they're still engaged, they're still trying to perform, and they're looking for that perfect heart rate to support their activities. So CLS can be demonstrated with an emotional rate response, and this can be studied or demonstrated with a color word test or perhaps with mental arithmetic. So if you reach down and get a sense for what your heart rate is about now, we can try this. I'll just take you through a few slides on color word testing. So what's going to happen is I'll flip to the next screen, and there's a word in the middle of the screen, and what you have to say out loud is the font color. Okay, don't read the word, just say what the color of the word is. So we'll flip through several of these kind of quickly, and we'll see how we do. And you, without moving, without breathing, can assess whether your own heart rate is adapting to that challenge. So on 3, I'll flip the screen and just read aloud the font color. 1, 2, 3, 2, 3, 2, 3, 2, 3. So you get there. That's the color word test I take every morning while I'm waiting to get my coffee in our hospital. You know, the coffee people are always wearing this Love Pink clothing line, and I'm always, every morning, it's like, you know, that doesn't make sense. So, but you can see that mental activity does in fact increase your heart rate. Studies have shown that can account for about 20 beats per minute in your heart rate on average. And we can measure this. So you take patients who are implanted with the pacemaker and you can program it with the CLS algorithm and then follow heart rate activities as judged by that sensor in response to different challenges. So here you are, in a rest period, and this is your basic heart rate at 60 beats a minute, or probably paced at 60 beats a minute at your lower rate limit. And then the patient does the color word test like we just did. And you see the acceleration in heart rate that's provided by the CLS algorithm responding to the associated increased contractility of the heart, which occurs as the catecholamines circulate. And then we switch the activity now to a arithmetic challenge, and we see the heart rate is not as high, but it certainly remains elevated compared to your lower rate limit. Then reprogram the device to traditional VVIR, because all of the devices also have the accelerometer sensor, and repeat the activities. There's a rest period, then you do the color word test, and then you do the mental arithmetic, and that sensor is not able to provide any change in the heart rate to the patient because they're not moving and they're not breathing harder with that level of exertion. So it's this subtle control that helps support physiologic function, which CLS is particularly useful for. So we can just talk about a few engineering concepts related to CLS. What we have is a pacing lead in the myocardium with the heart contracting around that pacing lead. And during diastole, when the heart is relaxed, you would think there's the least concentration of myocardium surrounding the pacing lead. And then at end systole, when the heart's contracting, that there'd be a greater concentration of myocardium surrounding the tip of the pacing lead. And what the device can then sense, and it can be with any lead, from any manufacturer that CLS works, is it senses the local impedance. And when there's myocardium concentrated, the impedance is higher. When it's blood that's most concentrated, the impedance is lower. And so the device is constantly able to sense those changes in impedance with every beat of your heart and adjust your pacing rate accordingly. So what we know and what's been demonstrated is that impedance correlates with cardiac demand. So here you have contractility and you have your impedance measurement, and those two measures are linearly related. So we can say, in fact, contractility is directly related to impedance, and measuring impedance becomes a useful surrogate for contractility, and by providing appropriate correlated pacing rate, we can match the required cardiac demand, or the cardiac demand that patient's entire physiologic system would find most beneficial. So what CLS does is it first builds a reference waveform. So here is the first 300 milliseconds of your systole, of your heart contracting. And what the CLS algorithm will do is it will take 8 impedance measurements during that first 300 milliseconds, and it builds a curve which typically has this shape. So this becomes your reference waveform. So you implant the device with CLS, you turn it on. In the first 10 minutes, there's rapid collection of this reference waveform. So the device is cycling through, collecting, and averaging, knowing that you are at rest, one, because you're still on the table, and two, because the accelerometer says you're not moving. So the accelerometer is not moving, you're building this reference waveform, and then your patient will go out, and for the first week, there'll be a rolling average that adapts to CLS continually. So it's continuously finding when you're at rest, rebuilding that template, and adjusting that resting template for you. And again, it knows you're at rest because the accelerometer is reporting no movement. With that template then, the device then compares to your resting template what your impedance values are relative to that. And as you increase in exertion, for example, you'll have larger deviations of your impedance from that reference template, and the device will adjust your pacing rate accordingly. So then you say, well, how much pacing are you going to provide based on those impedance changes? And this enters the concept of the exertional threshold rate. So there's a mathematical tool based on patient's characteristics which should establish what it thinks this value is. And then it's going to adjust your CLS pacing to say 20% of the time, on average, you should be above your exertional threshold rate and 80% of the time below. So it's going to adjust the curve and the amount of heart rate it's providing to achieve that 80-20 ratio. And these things are programmable as you tweak it for each individual, but out of the box, and what it ends up being for most people is exactly this. So this exertional rate, again, programmable. Nominal settings are just fine for 80% of your patients. So here's an exertional threshold rate for medium, which is your out-of-the-box setting. But if you find that's not working for certain individuals, that feature becomes programmable. So rather than increasing your response rate or whatever to the other sensors, you're now tweaking these sorts of variables to get the sort of rate variability which you think would most benefit your patient. And then the system has suggestions for pacing by indication. So if you have paroxysmal AV blocks, complete block sinus node dysfunction, vasal syncope, the device can make suggestions for you on what your pacing programming should be. So just a few clinical examples from our practice. Actually, these first slides were provided by Biotronic. Here we have a 54-year-old man. He's physically fit, diagnosed with chronotropic incompetence. He exercises a lot. He has a pacemaker. So programmed DDDR, he gets this heart rate histogram. You see that he spends most of his time at his lower rate limit. And indeed, with that accelerometer sensor, he does accelerate up to 130 beats per minute at times. Reprogram him DDD CLS, and his rate histogram now looks like this. And you'll see that he spends the majority of his time not at his lower rate limit. He's in fact faster than that, as his contractility is saying, I don't want to just be at 50 or 60 beats per minute most of the time. And the density of his heart rates collects around that point such that there's less excursion into the higher heart rate modes. We know that his activity is very comparable during these time periods. Here it's 10% activity, 9% activity. So you know he's basically kind of doing the same thing, and you can decide, and he can help you decide based on his response, which of those pacing histograms is best meeting his needs. We'll switch to this business of neurocardiogenic syncope, which is a problem that is referred to electrophysiology frequently. And how we understand this pathophysiology is that there will be a drop in both systolic and diastolic pressure at a time when a faint happens. And the pathology is that while blood pressure is declining because of vasodilation, the heart rate is also slowing. This is the time when the heart rate should be accelerating to fill those dilated blood vessels with blood so you don't have the syncopal event. But the pathology is that there is this early slowing, and these patients will then go on to faint. An actual tilt table test in this very sophisticated system, 18-year-old female with neurocardiogenic syncope, she's tilted, and we can see that her mean blood pressure is now dropping at a time when her heart rate is also dropping. She's highly symptomatic during this time. And on this system, you can also measure cardiac output and see corresponding to that, of course, the cardiac output is also declining, and we reproduce her faint. So this is the real pathology that we're trying to treat. Here is this 18-year-old female now implanted with a CLS pacemaker, and we see that in the first 19 hours post-implant, while she's still basically very much at rest with 100% inactivity, the contractility of her heart has given her this very nice physiologic heart rate histogram. And then she'll go on to demonstrate that with this pacemaker, her neurocardiogenic syncope is resolved. Begs the question, well, could any pacemaker really have achieved that clinical result? And perhaps, and we've seen that. We're going to look a little bit more closely for unique advantages here. Again, here's a 26-year-old male. He's having syncope with blackouts several times per month. He gets a CLS pacemaker, and at a time in the first 7 days post-implant, when he is still relatively inactive, only 2% activity, he is achieving a very nice physiologic range of heart rates based on contractility parameters, which can be subtle, but when the algorithm distributes them for you, you achieve very normal heart rates, which would be difficult to, I think, achieve with a regular sensing platform. So again, the advantage in vasovasal syncope, the first thing that happens is you have this peripheral vasodilation. So all your blood rushes into your extremities. In response to that, the heart feels underfilled, and it will give a very forceful contraction. In the pathology setting, that results in oscillations in your autonomic nervous system that results in your heart rate decreasing. In a regular pacing mode, only when the heart rate starts to decrease will the pacemaker speed you up, but often at that point, you're already on the floor. With CLS, so here you have the venous pooling, this vigorous contraction, and in response to this vigorous contraction, the pacing rate is elevated early such that blood pressure is stabilized, and hopefully we can abort the syncopal episode. So it's that upstream anticipation of the bradycardia based on this forceful contraction, which within 1 or 2 beats, you're already being accelerated. And hopefully that can make the difference in whether you faint or not. So there's this programming feature called the resting rate control. And what that is, if you're all sitting here, you know, how much should the CLS algorithm accelerate your heart rate during the color word test? By default, we use this and we say only 20. 20 beats a minute will allow you to increase or modulate while you're at rest. That is, of course, programmable, and this is something that you turn off in the setting of vasovasal syncope because that person may need to accelerate their heart rate by 80 beats a minute. Within a beat or two, should that massive increase in contractility be experienced in a way that they can abort their faint. So we're aware of this parameter. Out of the box, it's nominal 20. That's good for the chronotropically incompetent person who's not vasovagal, but for those individuals who are specifically getting a pacemaker for their vasovagal faints, we'd want to disable this feature. So some examples from our clinical practice. So first of all, a dual chamber pacemaker, MRI compatible with CLS. Here's a 72-year-old man. He's had bypass surgery, atrial flutter peri-op, which we ablated for him. His ejection fraction is entirely preserved. He seemed bradycardic. We gave him a 10-day ambulatory monitor. On average, in the real world, he's in fact profoundly bradycardic. So we implanted him with the dual chamber MRI CLS pacemaker and saw how he responded. So here's his flutter. We ablated that. He's sinus brady post-ablation. We give him the 10-day monitor, and here is his distribution of heart rates. So over 10 days, he's spending 73% of his time less than 60 beats a minute. Extremely sluggish for the level of activity he's trying to achieve. So he gets a dual chamber CLS pacemaker. Post-op day 1, there he is atrially pacing at his lower rate limit. And then we see how he evolves. So here's his 10-day ambulatory monitor. Here is his first overnight in hospital. So the first 21 hours, he's CLS 50 to 130. And we see that he's atrially pacing 77 beats a minute at a time when he has only 1% activity. And then going out of hospital, now over 169 days, same programming parameters, we see the range of atrial pacing that he achieves, and he's all sensed in the ventricle, so that's perfect. And still, he's only experiencing 11% activity level. So he gets this nice distribution of heart rates. His peak heart rate is off of his lower rate limit, probably where he likes it, and he's very happy with this result. You know, so it begs the question, which pacing lead should the CLS algorithm be looking at for contractility? And the thought has been it should be the lead in the ventricle, because that should see the largest excursions in impedances. That stronger pumping chamber causes larger fluctuations. You'd think the CLS algorithm would perform better if it's, you know, collecting its contractility data from the ventricle while supplying pacing in the atria. And that's a thought that our local Biotronic team has told us to anticipate, and we've challenged them on that and demonstrated that atrial only pacing also gives us really excellent results in CLS that seem almost indistinguishable from the dual chamber systems, which is, I think, a very interesting result. We were recognized for implanting the first single chamber MRI pacing system in the United States. A little bit by fluke, but when Biotronic did come out with that MRI compatible single chamber device, that was the first of its kind. The Medtronic device required 2 leads for its MRI compatibility. That's recently changed. Nevertheless, still, this is the device that has CLS, and it begs the question, how well does this perform when your only lead is an atrial lead? And we've had a fair number of cases where we've implanted only an atrial lead for chronotropic and competence. It's a bit of a European twist to patient management. This is much more common on the other side of the Atlantic, but it's something we've appreciated. So here's a 71-year-old male. He has a non-ischemic cardiomyopathy. His EF is 25. Again, a typical right atrial flutter. We ablated. His EF responds after that. He's profoundly bradycardic, and he gets an atrial-only CLS pacemaker. We knew that his AV node was healthy because he had a lot of RVR during his atrial flutter. So it's certainly able to conduct. We're not worried about the AV node disintegrating anytime soon, where a dual chamber system would be required. Here's an ECG of his flutter. We ablated that. He's now sinus brady here at 37 beats a minute in the outpatient setting. We asked him to wear a monitor, even though we were pretty sure he was slow. And sure enough, he spends 65% of his time at heart rates under 50 beats a minute. You know, someone who'd like to be active. His ejection fraction is resolved. He wants life, and he's very sluggish. So he gets a single chamber pacemaker, only a lead in the atria, and we're using the CLS algorithm, using the smaller contraction dynamics of the atrial chamber to reproduce his physiologic pacing. So here we go with him. Here's his original 12-day monitor. We put in the atrial pacemaker. Over the first 63 days, when his activity level is 9%, he achieves this heart rate histogram, pacing 94% of his time in the atria. And then subsequently, over the next 86 days, without changing in his programming, he's atrially paced 92% with a slight increase in his activity level of 13%. So it seems like the algorithm does a very good job of saying, we don't need you to be super active. We're going to achieve a physiologic range of heart rates for you, a little bit regardless of your activity level, because we're not dependent on your activity. If we see that range of heart contractility while your activity level is equivocal or changing by small amounts, we'll still be able to achieve that nice range of heart rates for you. And these are what the accelerometer sensor would have reproduced in each of those settings. Here he is a little bit more active, and you can see there is a little bit more accelerometer support, but nothing on the order of what the CLS algorithm is producing for this individual. And of course, he's enjoying that tremendously. In all fairness to the accelerometer, we could program it more aggressively, but I think we've all had those patients in the office where we're going up and up and up on, the aggressiveness of accelerometer pacing, and we can't achieve sort of the heart rates that our patients would like. Here's an attractive option where I think it would occur quite naturally. So, again, another example of atrial-only pacing. Here for an indication of recurrent syncope. This is a 28-year-old female who's had recurrent pre-syncope and syncope for 2 weeks. She thinks she's been bradycardic for about 2 years. Bluish hands and lips when she senses that her heart rate is low. Her heart is structurally normal. She's in her hospital because she's fainted. The hospital telemetry is showing her on average to be sitting at the 40-50 beat per minute range. We implanted her with an atrial-only pacemaker about a year ago, and then took her through several programming iterations to find what was best with her. It was interesting. We initially programmed her with an AAIR setting, so a accelerometer-based pacing modality, and with that she was paced 30%, mostly at her lower rate limit, and even with the lower rate limit, her symptoms are completely resolved. It was quite amazing. Her fatigue is better. She's no longer dizzy. Her headache's better. She's sleeping better. No more syncope. And you think, wow, you've really met the needs of this individual. Then we went on to try CLS to see if we could offer her additional refinement and benefit, and that was an interesting course. So here she is in our hospital, sinus bradycardia. She gets an atrial-only pacemaker. We'd like to give her CLS pacing. This is a very young individual. We're all reluctant to implant, so it's nice to have one lead, minimum hardware for as long as you can get away with it in someone who is very young. And then her post-op ECG, here she is atrially pacing at her lower rate limit. And then we see how that evolves. So here is day 0 to 14 post-implant with these programming settings. She is programmed AAIR. She's atrially pacing 30%, and you can see it's mostly at her lower rate limit. Her night rate lets her go to 50. She gets a little bit of pacing. And the rest of it, she achieves for herself a very nice physiologic range of heart rate, so it seems. Here, her activity level during that time is about 6%. So based on that, we said, if we've met your needs without a sensor, let's program off the sensor. So we programmed her AAI, and now she's atrially pacing 15%, still at her lower rate limit. Profile looks very good. You're like, well, we're pacing less than the atrium. Maybe that's helpful. We're not too concerned about that. Why don't we try the CLS algorithm? So we actually sent her out of the office with the CLS at nominal settings, and she came back same day, and she's like, this is crazy. And we see that sometimes as the algorithm adjusts, it'll give you fast heart rates. That was bothering her. So we programmed the CLS to the very lowest setting for CLS. This is an atrial-only pacemaker, so it's getting all that contractility dynamics from the top chamber. And so here now she achieves this range of heart rate histograms, very interestingly, at a time when her activity rate is 17%. That's 149 days of data. And she's like, this is better. This is better. This resolved all of her concerning clinical episodes. This is more physiologic and seems to be meeting her needs. So just an interesting example of how CLS can offer refinement in that pacing therapy in a way that gives the patient the most satisfying result, even though as a doc, you're like, I really have solved her problems, even with a very conventional pacing modality. So looking at just another one for chronotropic incompetence. This is an interesting story. It's a 53-year-old, very healthy male professional. He does report limited exercise since childhood. He couldn't run around the track as fast. He didn't do as well in gym, but there was nothing apparently wrong with him. The time I met him, and it wasn't in the office, he had an incidental finding now of a PFO on his echo. His heart's otherwise completely normal. He has normal coronaries. He's not shunting across the PFO, and he is scheduled for PFO closure. And he's hoping that this will solve his problems, give him a little bit more exertional capability. So he gets his PFO closed in April. I saw him socially 4 months later, Said, how's it been since the closure? Symptoms are unchanged. In general, his blood pressure is a little bit lower, so you think somehow it's adjusting to, it wasn't trying to normalize flow across the shunt, so he's able to improve on his blood pressure. He says, anecdotally, my heart rates are generally just very slow, but I can reach 150 beats a minute with intense exercise, and he cites burpees as his intense exercise. We offered him a 5-day ambulatory monitor. He wore it actually for 5 days. And it really showed quite profound chronotropic incompetence. He was implanted with an atrial only pacemaker last December and sub-pec implant for cosmetic concern, and has really shown us a dramatic clinical response to the pacing. So here he is in our office, walks into the office, his ECG shows sinus rhythm 44 beats a minute, pretty slow. We give him the 10-day monitor. He in fact we got through 5 days. And he can certainly, while he's exercising, get up to 135, 140 beats a minute. But where is he living? Very slow. 79% of the time he's less than 60 beats a minute, spends a lot of time less than 50 and even in the 40s. And we could advise him, your heart rate really is sluggish, and this may in fact be your primary problem. So he got the atrial only pacemaker. Again, that principle of just minimal hardware, and somebody who's very concerned about hardware finds this idea of a pacemaker very threatening to his sense of youthfulness. His Amplatz closure device is here, and we could confirm that on the fluoroscopy, but that's what the Amplatz looks like on an X-ray. And so there's his sub-pec implant 2 weeks post. He's happy with that, so luckily that went well. On postoperative day 1, here he is atrially pacing at his lower rate limit, 50 beats a minute. And we see how he evolves. So here's his outpatient monitor. And then in the first 16 hours in hospital, he's programmed. We said, the best settings for you probably in the real world will be 50 to 150. And we programmed that right out of the get-go. In the first 16 hours, his activity is 0 because he's laying in bed. His sensor says only lower rate limit. And in fact, he's only paced at his lower rate limit at 94%. He goes out for the next 6 days. At the 50 to 150, he achieves this heart rate histogram with a pacing burden of 89%. Sensors still wouldn't have provided that for him, but he notices he'll be at rest and his heart rate will be like 120 quite frequently. Driving home from the hospital, they were going to turn back, and he was having this ongoing stuff at times. So the algorithm, I think, was taking time to adjust for him, and it probably would have sorted itself out. But he came back in, and we reprogrammed him 50 to 140, and that was better. He stayed there for 87 days, paced in the atria 78%, had an activity rate of 13%, and still that accelerometer not giving him much acceleration. He's achieving this. Came into the office, everything was great, feeling so much better, exercising well, sleeping well, mental clarity. Would like to exert himself a little bit more. So we went back to that 50 to 150 range of pacing, and here's data over 59 days. And you just see, now he's got an activity rate of 18%, so it's not entirely comparable, but we see that he is spending a little bit more time faster. What he does in kind of his ADL range is in fact a little bit less pacing and slower, but he does have these larger excursions. And so you ask him, is this better for you? Show him the data and ask him, very much involved, show him and ask him how he'd like to proceed. So here is his workout monitoring. He wears this monitor. He works out for 40 minutes. And if his heart rate breaks 50 for long enough, it'll start to turn color. And if he gets to 100, the color turns red. And he can see how well he's exercising. So 10 days before his pacemaker, that's what a 40-minute workout looked like. His time in the 50 to 100% peak heart rate zone, only 10 minutes during that exercise. He gets back to his vigor exercising a month following his pacemaker. And so here's a workout 2 months after his pacemaker. And the colors turn blue and then yellow and green and red as he has that time above his 50% threshold. Now he's spending 47 minutes of a 54-minute workout, at that faster heart rate, and he's feeling great. He's able to get fit, he's losing weight. It begs the question, could you do that with any pacemaker? To a certain degree. But I still think there's advantages to achieving that with CLS. So he's very verbal. Text messages, often at 4 or 5 o'clock in the morning. Several times, post-operative day 4, he's like, several times I feel like my heart was racing. So this is 4 days after the pacemaker. And checked with my app. So he's got the iPhone app. And he's like, sure enough, the heart's racing. So that's when we turned it down. Post-operative day 5, I charged up the stairs in our house for the first time. More rapid heartbeat is unfamiliar to me. However, I could tell a difference in energy level when I got to the top. Very exciting to feel the pacemaker working. Post-operative day 7, feeling really, really good this evening. My mind is very, very focused and energy level is really great. So you're like, okay, we're helping him. Post-op day 13, last night I engaged in intense sexual activity for the first time since the pacemaker, and it was a completely different world. No sudden drop in energy. I felt like my heart was supporting. Energy level remained really high throughout, and I felt like I could keep on going. So, what part of your body is moving? It's not the pacemaker necessarily. So, and at 6 months, this is just last week. So the high at 150 is perfect for me. I've added lots of cardio to my workout and see that 150 all the time. Did a 22-mile bike ride and felt fantastic. So if we tinker with these people, we can find good settings. Here's a 32-year-old female. She's had 5 ablations of her sinus node for inappropriate sinus tachycardia, all at a time when she was hyperthyroid. Her last ablation was at age 27, so 5 years ago. She had a single-chamber atrial pacemaker. It was not a Biotronic device. For 2 years, 2008 to 2010, that device was removed for its dysfunction. In 2012, she had a syncopal episode causing a motor vehicle accident. She's in the ditch. She met her husband there. He was the first officer responding, so that turned out well. So I guess she decided not to sue. Her heart's completely structurally normal. And then last summer, she had thyroidectomy. So now the thyroid's gone because it was always hyperthyroid. Her tachycardia has improved with the thyroid out. She's had healthy weight gain. But she believes she's having profoundly bradycardic episodes and she thinks she's losing consciousness. So we said, how about we monitor you in the real world setting? We found no concerning bradycardia. The heart rate was very irregular with a pattern seemingly to indicate a sinus node exit block. So she also got an atrial only pacemaker, the young age and minimal hardware concept. And then in someone where CLS responds just fine with atrial contraction dynamics. So here's her office ECG. This is when she walks in. This does not look like somebody who needs a pacemaker. She's sinus at 87. She wore a 7-day ambulatory monitor, and this was the result. Again, not somebody who looks like they need a pacemaker. She spends most of her time 60 to 70, easily accelerates to high heart rates, but she's got this odd plateau shape, which I'm learning can represent a high burden of ectopy, either atrial ventricular ectopy. And then on her tracings, when she's actually activating her monitor saying I'm having symptoms, she has activity like this. So it's all sinus, but she'll have these sort of sinus pauses, repetitively. Nothing overly concerning, but this is really bothering her, and she's fearful that there's going to be another car crash, and she's very uncomfortable with this. So based on that and the possibility of the sinus node failing further, at a time when she's not monitored, we offered her an atrial-only pacemaker, tattoo-sparing procedure. Here's her first pacemaker. Here's the new one. We have since moved this sub-pec because she jogs so much and it was wearing thin and causing pain. So there's been a repeat procedure. Here's her 7-day monitor. We program her ALCLS 50, days 0 to 5. That's her histogram at a time when her activity level is only 1%. And then then 3 months later, over 34 days, same programming, her atrial pacing burden is about the same. Now her activity level has improved to 11%. And then over a subsequent 76 days, when her activity level has decreased now by half to 6% for whatever reason, she is still achieving a very similar range of heart rates, even a little bit more brisk if that's possible. And that being the independence of the CLS algorithm on on activity to provide your heart rate. So it will continually rescale that resting heart rate profile and adjust the range of heart rates that the pacemaker is delivering you over the course of the day based on that plot. So the same very physiologic heart rates in her kind of her ADL range, regardless of the level of activity and over long periods of time. And her symptoms are completely better. She feels regular. She's not having that stuttering anymore. Jogs about the same because it would all resolve with activity, but confident, not fearful, and very satisfied with that result. So future opportunities that I'd be interested to hear from Biotronic is CLS performance and atrial only pacing. Can we study this? And is there really differences in the contraction dynamics and how the CLS algorithm responds? And then CLS for CRT with any LV offset. So what if we wanted to program LV offsets? Could we continue to have a CLS-based pacing modality? So we're hoping those things are waiting for us in the future. So thank you very much. We're on the other side of the lake.